So this InstaLecture number 108 would be on MEN syndrome, multiple endocrine neoplasia syndrome. And I have two key objectives for this InstaLecture session. Number one, to tell you the difference between MEN1 versus MEN2 versus MEN3 and MEN4. That means including the latestly introduced MEN4 syndrome, how to differentiate between MEN1, 2, 3, 4 syndrome. And second, how to train your brain to pick up any case study and detect the type of MEN syndrome within 10 to 20 seconds. And this is not an empty promise. I ensure you that if you follow the guidance which I'm trying to provide in this InstaLecture session, you'll be able to do yourself at the end of this session after a few minutes, 10, 15 minutes. So first thing first, what is MEN syndrome? MEN syndrome stands for, or MEN syndrome, it's better said as MEN syndrome. Multiple endocrine neoplasia syndrome. M for multiple, E for endocrine, and for neoplasia syndrome. You have read about a lot of inherited cancer syndromes in other places, like while reading about renal cell carcinoma, you have read about VHL, von Hippel-Lindau syndrome, which is also a inherited cancer syndrome because they can have pheochromocytoma and they can have renal cell carcinoma. You have read about the Lynch syndrome while reading about the GIT. So these are all inherited cancer syndrome. This is also a inherited cancer syndrome, inherited neoplastic syndrome, which is usually inherited in an autosomal dominant format and involving the endocrine organs. But obviously not only the endocrine organs, I would later explain that it can also involve skin and other places. So the basic definition or the basic idea of the multiple endocrine neoplasia syndrome is this, that this is a inherited syndrome which usually involves two or more endocrine organs, and the patient usually develops some neoplastic lesion, benign or malignant. Not only neoplastic lesion, also proliferative lesion like hyperplasia can also develop, like hyperplasia of parathyroid could develop. Any kind of proliferative lesions could develop. And that could develop simultaneously together, or it could develop in an interval. This is the concept of synchronously and metachronously. I would mention about that later. So this is the MEN syndrome, and classically we divide them into MEN1, MEN2, MEN3, MEN4 syndrome. The MEN1, let's start with the MEN1 syndrome. I think MEN1 syndrome, the most common thing you have heard about them, that they are the syndrome of 3P, but in the last 2 decades, we have found a lot of other findings which are very much important in the diagnosis of MEN1 syndrome. MEN1 syndrome is also known as Warm-Marsh syndrome. Do not confuse it with Warner, W-E-R-N, which is progeria. It is Warm-Marsh syndrome. And in this syndrome, mostly we get, which you have already heard, that 3P, that means proliferative lesion of the parathyroid, proliferative lesion of the pituitary, and also pancreas, and also gastrointestinal system. But in the last few decades, we have found that there are other manifestations also very much crucial in the diagnosis of MEN1 syndrome. Most important one which we like to discuss is angiofibroma of the skin. Angiofibroma of the skin could be seen in up to 80% cases. And angiofibroma, I think you have read in tuberous sclerosis, but this has also been found that angiofibroma, particularly the facial angiofibroma, could be a useful manifestation to diagnose MEN1 syndrome. Also, they can have cholangioma, they can have lipoma, they can have carcinoid tumor, particularly thymic carcinoid is an aggressive tumor seen in this patient. So, and also they can have adrenal adenomas. So, not only the 3P, but also other endocrine tumors and other skin tumors could be seen in this patient. Skin lesions could be seen in this patient. Now, coming to talk about the 3P, the most common manifestation of MEN1 syndrome is primary hyperparathyroidism. I think I've already described there are 3 types of hyperparathyroidism in my other InstaLecture: primary, secondary, and tertiary. Primary hyperparathyroidism is usually seen in this patient, which presents with parathyroid adenoma. And this is often the first manifestation of MEN1 syndrome. And as you know that primary hyperparathyroidism typically present with asymptomatic hypercalcemia. That means the serum calcium level is little bit higher than the normal level. Normal is usually 8.5 to 10.5 mg per deciliter, and this would be a little bit higher, and the patients would not be present with very much symptoms. It will be asymptomatic hypercalcemia. And this is the primary hyperparathyroidism is the most common and typical manifestation seen in the MEN1 syndrome, seen up to 95% of the cases. And the difference between sporadic primary hyperparathyroidism versus MEN1 associated hyperparathyroidism is this, that usually it has seen that usually the parathyroid adenoma normally when happen without MEN syndrome, they usually involve one parathyroid gland out of 4. But if they are involving the MEN1 syndrome, typically they involve multiple parathyroid glands. This is one of the characteristic features. Second is the pancreatic and gastrointestinal neuroendocrine tumor. And the most common one is seen is gastrinoma, secreting gastrin tumor. But here is the catch, that gastrinoma in MEN1 syndrome is not most commonly seen arising from the pancreas, but rather from the duodenum. And most of the cases, really, there is small submucosal lesions seen from the duodenum. This is an important concept that you need to keep in mind. And these pancreatic and duodenal neuroendocrine tumors are often cause of death in this patient. And other than gastrinoma, which is associated with Joling-Relison syndrome, we can also see the patient of insulinoma, glucagonoma, VIPoma, that secretes the vasoactive intestinal peptide. So this kind of neuroendocrine tumors could be seen. But they not only arise from pancreas, but also from the duodenum that you need to keep in mind. And more commonly, the gastrinoma, which is the most common neuroendocrine tumor that arises from the duodenum. And the third characteristic P, which you already know, is pituitary. Pituitary adenomas could be seen. Pituitary adenoma, the most common pituitary adenoma which you see in them is prolactinoma. So if it is in female, they can present with some kind of menstrual abnormality. They can present with galactorrhea. In males, they can present with loss of libido, erectile dysfunction, this kind of feature. And also, other than prolactinoma, they can also present with somatostatin, not somatostatin actually, somatotrophic secreting tumor. That is, they would be usually present with acromegaly. So either the pituitary patients, they would be presenting with prolactinoma, or they would be presenting with acromegaly. These are but prolactinoma is the most common pituitary adenoma which would be seen in this patient. So if I summarize, and another key concept that you need to keep in mind about the MEN1 syndrome, that they usually are associated with the mutation of the MEN1 gene. And MEN1 gene usually produces a protein known as menin. And menin protein has many roles. That means sometimes they suppress the tumor, sometimes they can promote. But in this case, they have seen when they develop the MEN1 syndrome, they usually, there is a suppression of the tumor suppressive activity. So minus, minus, plus, because when your tumor suppressive activity of the menin is suppressed, that results in the formation of the MEN1 syndrome. So MEN1 syndrome, the key concept in a nutshell before I go to MEN 2, 3, 4. MEN1 syndrome, you need to know that it's not only about 3P, but also about the duodenal neuroendocrine tumors and some other tumors like adrenal adenoma. Nowadays, they also describe thyroid adenoma. There's also presence of carcinoid, thymic carcinoid, bronchial carcinoid, and also a lot of skin lesions, particularly angiofibroma is very much important, collagenoma and lipoma. And obviously those 3Ps are there. That means anterior pituitary, parathyroid, and pancreas. And the most common manifestation, which is usually seen up to 95% patient, is primary hyperparathyroidism, present with parathyroid adenoma. And most common cause of premature death in this patient are usually these neuroendocrine tumors arising from the duodenum and the pancreas. And those tumors could be gastrinoma, could be insulinoma, could be glucagonoma, could be VIPoma, that means which release the vasoactive intestinal peptide. And out of pituitary tumors, adenomas, anterior pituitary tumors, we most commonly see prolactinoma. Sometimes also they can present with acromegaly. These are the key concepts with MEN1 gene, which is located on chromosome number 11. Now let's move to MEN2 and 3. Now MEN2 is also called MEN2A, and MEN3 is also called MEN2B. So when we use the term only MEN2, it basically means MEN2A syndrome, which is also known as Sippel syndrome. And MEN3 is nothing but MEN2B. So don't be confused when you get the term MEN3 or only MEN2. MEN2 means, some people also describe MEN2 as MEN2A and MEN2B as 3. So MEN2B is nothing but 3. And MEN4 is different. I would discuss at the end, which has been discovered most recently. Now, when you read about the MEN2, or which is also called MEN2A or Sippel syndrome, it has a lot of forms actually. Like one is classical MEN2A form. Another is associated with lichen amyloidosis, which is a skin lesion. Another form is familial medullary thyroid carcinoma. Another form is associated with Hirschsprung disease. So it has MEN2A or MEN2 or Sippel syndrome has 4 forms. One is classical MEN2A. Another is they could be associated with a skin disorder, lichen amyloidosis. It could also be associated, another form is associated with Hirschsprung disease. Another form is associated with familial medullary thyroid cancer. They only have medullary thyroid cancer. So these are the 4 subtypes of MEN2A or MEN2 or Sippel syndrome. This is the next concept that should be in mind. But mostly when you read about MEN2 or 2A syndrome, you might not have heard about this because we most of the time describe the classical MEN2A syndrome. And classical MEN2A or MEN2 syndrome or Sippel syndrome, usually they have 3 key manifestations. Most common manifestation is obviously medullary carcinoma of thyroid, which is a neuroendocrine tumor arising from the parafollicular or C cells of the thyroid, which secrete calcitonin, which acts as a tumor marker. And they usually present with a thyroid nodule, or sometimes they can present with metastasis. Second, and this is the most common manifestation, and a very important concept here, that medullary carcinoma of thyroid could occur at a much earlier age, and almost 100% of them, they could develop medullary carcinoma of thyroid. So that's why if you are diagnosed with MEN2A or 2 or MEN2B or 3 syndrome, it's advised to have a prophylactic thyroid reductive, prophylactic removal of the thyroid, because anyway you are in future you're going to develop medullary carcinoma of thyroid, which would be aggressive and associated with MEN syndrome. The next component of MEN2 or MEN2A or Sippel syndrome is pheochromocytoma, which you usually know that they typically arises from the adrenal medulla, which is a tumor from chromaffin cells. Chromaffin cell of adrenal medulla, these are called chromaffin cell because they're cell of origin, because they have affinity for chromium. So chro for chromium and affinity is affin. That's why it's called chromaffin cell. So pheochromocytoma is another part of this thing, but they are less commonly seen. The most common manifestation of MEN2A or 2 syndrome is medullary carcinoma of thyroid. And pheochromocytoma, you know that they can present with some paroxysmal episodes of headache, palpitation, tachycardia. They can have sweating, hypertension is the most common manifestation. This will be the presentation in them. And in this MEN2A syndrome, the third manifestation, the third key manifestation is primary hyperparathyroidism, which is also associated with parathyroid hyperplasia also. So MEN2 or 2A or Sippel syndrome has 3 key manifestations. The classical variant, because I first told you that MEN2A 2 or 2A, which is the same thing, or Sippel syndrome has 4 subvariants. And out of the 4 subvariants, the 4 subvariants I told, one is classic variant, second is associated with a skin manifestation lichen amyloidosis, third is association with Hirschsprung disease, and fourth, familial medullary thyroid carcinoma. Familial medullary thyroid carcinoma was previously thought to be a separate entity. Now it has been put under the umbrella of a subtype of MEN2A or MEN2 syndrome. Now, coming to the classic MEN2A syndrome, it has three key manifestations. One I told you is medullary carcinoma thyroid. Second is pheochromocytoma. And third is primary hyperparathyroidism associated with parathyroid hyperplasia. Now, if you compare this with MEN3, which is also known as MEN2B syndrome, the first two components are same. I mean, they also have medullary carcinoma thyroid, they also have pheochromocytoma, but they don't have hyperparathyroidism, primary hyperparathyroidism. So a key differentiating feature between MEN2, which is also known as MEN2A, versus MEN3, which is also known as MEN2B, is that in MEN2 or 2A, they have hyperparathyroidism, which is absent in MEN2B. Now in MEN2B, the common factors in MEN2A and 2B or MEN2 and 3 are medullary carcinoma thyroid and pheochromocytoma. But MEN2B or MEN3, they don't have primary hyperparathyroidism. Instead, they have two other key features. One is marfanoid habitus. Marfanoid habitus means anything ending with OID, oid, means they look like that, they smell like that, but actually they're not like that. So they look like Marfan syndrome patient because they have tall stature, and they can have the typical appearance of the Marfan syndrome. The skeletal deformities could be there, but usually they're lacking features, specific features like aortic root abnormalities, or they don't have the lens dislocation. So they actually are not truly the Marfan syndrome patient. They're called marfanoid, like leukemoid, actually, which is not truly leukemia, but leukemoid. Or you have epithelioid cell you have seen in chronic granulomatous inflammation, which is not truly epithelial cell in macrophage. So anything ending with OID means that's not truly like that. Like metalloid, bismuth antibody, they're not truly metal. That's the idea. Android, which is not truly the Android operating system, which is not truly the human, but look like human. That's the idea. Acts like human. So they have marfanoid habitus, and they also have oral and mucosal neuroma. That is the manifestation. So skin manifestation neuroma is here in MEN2B or MEN3 syndrome. And in MEN1 syndrome, the skin manifestation would be angiofibroma, lipoma, and collagenoma. Often I have noticed that this part is not included in many places, and they are not, many times we are not aware that MEN1 syndrome is associated with certain skin manifestation. Please keep that in mind, that they are associated with MEN1, associated with angiofibroma, collagenoma, lipoma. These findings, these are very crucial. And MEN2 or 2A and MEN3 or 2B, this syndrome are usually associated with mutation in the RET gene, proto-oncogene, which is located on chromosome 10. And MEN1 was located on chromosome 11. That's a key concept. And in MEN, another key concept is here actually, that medullary carcinoma thyroid, when they are seen in MEN2B, they are found to be more aggressive. That is one of the points they have noted. Now, another important point is that this is associated with gain of function mutation of the RET proto-oncogene, and loss of function of RET proto-oncogene associated with something else, Hirschsprung disease, that has been seen. So that you need to keep in mind. And I'm talking about this classical MEN2A or 2 or MEN2B or 3 syndrome. That's the point. But this genetic manifestation have some variations in some other individuals that you need to do. The latest one which has been discovered in the MEN syndrome, that is called MEN4 syndrome, Some people used to call it MEN1 syndrome. And that is due to a mutation in the CDKN1B, a cyclin-dependent kinase inhibitor 1B gene, which is located on chromosome 12. And they look like MEN1 syndrome because they can also have parathyroid adenoma. They can also have pituitary adenoma. But in MEN4, they also have some tumor of the reproductive organ, like testicular tumor they can have. They can have some cervical neuroendocrine cancers, tumors. This is another key difference between MEN1 versus MEN4. And if you look at the location of the chromosome, I found it quite amusing because MEN1 is a mutation in the MEN1 which is located on 11, MEN2 or 2A or 2B or 3, they are usually due to the RET, rate protoncogene mutation, which is on chromosome 10, and the CDKN1B that is usually on chromosome 12. So 10, 11 for 1, 2 and 3 for 10, and 12 for 4. So they are located nearby actually also. That means 11, 10, 10, and 12. That is the point. So, and this one is the latest in the list of this latest inclusion in the family of the MEN disorders, MEN disorders, multiple endocrine neoplasia disorders. And this multiple endocrine disorder, the MEN4, as I mentioned, you need to keep in mind that they are quite similar in the manifestation with MEN1, but their mutation is different, CDKN1B mutation. And they, like MEN1, they have pituitary adenoma, they can have parathyroid adenoma. But additionally here, they usually have the reproductive organ. Now I'm going to tell you how, as I mentioned or promised earlier at the beginning, that how you can figure out the type of MEN syndrome within 10 to 20 seconds. Mostly, they would talk about MEN1, MEN2, and MEN3. MEN4, I already told you how to differentiate. If you get any MEN syndrome, they're talking about pituitary tumor. Most of the cases, it would be MEN1. Because MEN2 and MEN3 usually are not associated with pituitary tumor, that they need to be. So if they're giving a history of pituitary tumor, and there are also some neuroendocrine tumor, and there are also angiofibroma of the skin or lipoma of the skin, and also they're talking about hyperparathyroidism or increased serum calcium level, you need to think about MEN1. So my advice number one would be that if they're talking about pituitary lesion, just check that are they talking about some reproductive organ tumors or not. If that is not, that mostly not type 4, which is the latest inclusion. And I don't expect that this type would be always given in the case studies actually. So mostly if you get pituitary lesion, think about the MEN1 syndrome. Next thing, if they're talking about parathyroid hyperparathyroidism or hypercalcemia, you need to keep two things in mind, MEN1 and MEN2 or 2A or simple syndrome. In that case, you look for that, are they talking about pheochromocytoma? Pheochromocytoma is a typical manifestation of MEN2A and 2B. MEN2A means just MEN2 or 2B. Some pheochromocytoma rarely been reported in MEN1 syndrome, but that the least probability that they would add you in that way because it's quite rare. So if you are getting parathyroid, you have to think about MEN1, hyperparathyroidism MEN1 and MEN2A. And an easy way to differentiate between MEN2A or 2 versus MEN2B or 3 is the presence or absence of hyperparathyroidism, primary hyperparathyroidism. If primary hyperparathyroidism is present, hypercalcemia they are providing, that is MEN2 or 2A, and if it is not provided, that would mean 2B or 3. Then this oral or mucosal neuroma and marfanoid habitus would be instead there given in cases of MEN2B syndrome. And if they're talking about this neuroendocrine tumors, you can also think about MEN1 syndrome. That is one key point. So some key points that could help you quickly, as I mentioned you, easy versus MEN1 versus MEN2 versus MEN3, because I'm keeping as the latest entity MEN4 out, but still you can make it easy because MEN4 is nothing but pituitary adenoma, parathyroid adenoma, and some reproductive organ tumor. So you can easily figure it out. MEN1 versus MEN2 versus MEN3. If pituitary lesion is there, it is MEN1, not MEN2 or MEN3. If you are confusing between MEN2 and MEN3, look at parathyroid, primary hyperparathyroidism is present or absent. If primary hyperparathyroidism is present, is MEN2 or 2A or C. If it is absent, that is MEN2B. And MEN2B will also look for the marfanoid habitus or mucosal neuroma. And also keep this in mind that if there is coexistent both pheochromocytoma as well as they're talking about medullary carcinoma thyroid, a thyroid nodular lesion, then there are two possibilities. Either it could be MEN2A and 2B. And then just look at the history that are they talking about anything about hypercalcemia, primary hyperparathyroidism. If that is present, it is MEN2A. If it is not mentioned or serum calcium level is normal, then it is MEN2B syndrome. So in a nutshell, these are the way to approach these cases. And I think if you follow these principles, you can very quickly, within 10 to 20 seconds, you can make out the diagnosis. So just in a nutshell, what I told you, that multiple endocrine neoplasia syndrome is an inherited syndrome, mostly then inherited in autosomal dominant format, inheritance. And it's a inherited proliferative lesions of multiple endocrine organs. Having said that, they can also involve skin and other things I mentioned. MEN1 syndrome, Wormer's syndrome also known as, most common manifestation is primary hyperparathyroidism, usually present with parathyroid adenoma. Most common, they present with neuroendocrine tumors of arising, particularly gastrinoma arising from duodenum. Duodenum is the most common site of gastrinoma in case of MEN1 syndrome. It is not pancreas. Keep this in mind. Neuroendocrine tumors could be gastrinoma, which is the most common, could be insulinoma, could be glucagonoma, could be VIPoma, where the vasoactive intestinal polypeptide hormone is released, also known as pancreatic cholera, this condition. Watery diarrhea syndrome. And this, the next important concept that the most common pituitary tumor, because anterior pituitary tumors are also part of MEN1 syndrome, is prolactinoma. Sometimes they can also present with, other than prolactinoma, they can also present with acromegaly, excessive growth hormone secretion. And they are usually associated with MEN1 mutation, which is for many. Next, MEN2 or 2A, same thing, also sickle syndrome. Some people call it MEN2, also call it MEN2A. They are usually associated with RET rate, proto-oncogene mutation on chromosome 10, and it has four sub-variant. One is classical MEN2A. Second is associated with skin lesion, cutaneous lichen amyloidosis. Third variant is associated with Hirschsprung disease, and fourth is familial medullary thyroid carcinoma. Now in the classic one, classic MEN2A or MEN2, they have three key components. One is, most common is medullary carcinoma thyroid. Second is pheochromocytoma. And third is primary hyperparathyroidism, parathyroid hyperplasia. In MEN2B, which is also known as MEN3 syndrome, the first two manifestations are just like MEN2 or 2A. That means they also have medullary carcinoma thyroid, which is a neuroendocrine tumor of parafollicular cysts from the thyroid. They also have pheochromocytoma, which is a tumor of adrenal medulla chromaffin cells. but they do not have primary hyperparathyroidism in MEN2B. Instead, they have Marfanoid habitus, oral mucosal neurome, skin lesions are there. And in MEN1, I also mentioned, please keep this in mind, that MEN1, there are many other lesions also other than 3P. Don't be obsessed with the 3P only, because there are, as I mentioned, angiofibroma of the skin is a characteristic lesion of MEN1. There is lipoma could be present. There could be thymic carcinoid could be present. Carcinoid tumor is also seen. Adrenal adenoma is also seen a part of manifestation of MEN1 syndrome. So these manifestations could be there in your case study for MEN1 syndrome. Skin lesions, and the common problem is that whenever they see skin lesions, usually students jump into conclusion. I've seen that it's a MEN2B or MEN3 syndrome. It's not like that. Angiofibroma, skin lesion, lipoma is also a manifestation of MEN1 syndrome characteristic that you need to keep in mind. And MEN4, the latest inclusion in the family, MEN syndrome family, as I mentioned, they are quite similar to MEN1, but they usually also have some reproductive organ tumors and CDKN1B mutation on the chromosome number 12, that is the cyclin dependent kinase. These are the key concepts that you need to keep in mind about the MEN syndrome. And I hope that this is quite useful for you to make out any diagnosis of the MEN syndrome. Thank you very much for listening.